разрешите приступить к первой сессии. У нас сессия заглавлена «Структурные детерминанты эпидемии ВИЧ, туберкулеза, гепатитов в Восточной Европе и Центральной Азии». Мы будем в течение сессии обсуждать и слушать доклады двух выступающих. Я хотел бы представить Мишеля. Наверное, все, что про него уже могли рассказать, рассказали. Может быть, я сделаю такую одну ремарку. Действительно, во всех странах авторитет Мишеля очень высокий. Я рассказал сейчас такую историю из Беларуси. У нас в эту пятницу Мишель будет на конференции с похожим докладом по наркологии. Когда мои коллеги, эпидемиологи, инфекционисты, гинекологи узнали, что будет Мишель, они очень стали проситься, можно ли нам тоже прийти на конференцию по наркологии, потому что там будет Мишель. То есть это человек, объединяющий разные профессии, междисциплинарно работающий.
Спасибо большое, Алексей, Николь. Добрый день снова всем. Прошу извинения, я буду выражаться на английском языке, так как я готовил мою презентацию по-английски, мне будет полегче. Спасибо за ваше понимание. А где здесь, куда здесь нажимать? Зеленый, да? Хорошо. So, I would like to speak about drug use and drug injection as a driver. I'm saying drug injection. I'm not saying people who inject drugs. As driver of the epidemic in Eastern Europe and Central Asia. So this first slide is about the fact that unsafe drug injection, and particularly from the beginning heroin injection, has been a key driver of the HIV and hepatitis epidemics in the region. And this has started in the mid-90s, at times where the region was undergoing an economic, political, social, societal, I would say, crisis following the collapse of the Soviet Union. And that led to new freedoms of cross-border trade and travel, and led, as you all know, to an explosion of drug use across the region. For example, the number of opioid-addicted people increased by more than ninefold in the first 18 years of post-Soviet Russia in the Russian Federation. Now, unsafe drug injection remains today a key driver of the HIV and hepatitis C epidemics. Every one of you is familiar with the figures showing that in terms of percent, the relative percent of people acquiring HIV who are people who inject drugs is decreasing as 100% being the number of new cases, and let's say heterosexual and sexual transmission increases in the relative amounts. But if you look at absolute numbers rather than relative proportions, then things do not change much. In Russia, for example, in the last 6 or 7 years, it's always been 45 to 50,000 new infections among people who are using or have been using injecting drugs. The current estimate, according to the World Drug Report, of the number of people who inject drugs in the region is 302 million people. That is 1.3% in terms of prevalence, and that prevalence is 4 times higher than the overall prevalence of injecting drug use across the world. The HIV prevalence among people who inject drugs in the region is a mean of 25%, and this is almost 2 times the global average. And this means that there's approximately 750,000 HIV positive people who inject drugs in the region. The prevalence of hepatitis infection, hepatitis C, is 65%, meaning actually 2 million people that are HCV positive people injecting drugs. And as you all know, the HCV prevalence among HIV positive people who inject drugs is high, in between 50 and 75%. At the bottom of the slide, I've put numbers that I have been working on for this particular meeting and that surprised me myself. The first number I knew, I took it from UNAIDS, it is that there is an estimate that globally, people who inject drugs are 22 times more likely than the average population to acquire HIV infection. But the new number here is that when it comes to hepatitis, it is 1,000 more, 1,000-fold increase in the rest of the risk among people who inject drugs as compared to the rest of the population. Now, I've given you average numbers, but some of the numbers can be actually very high. And this is taken from a study published a year and a half ago, and you can see prevalences of HIV infection in the first column to the left, among people who inject drugs in some cities in the Russian Federation, 57% in Ekaterinburg, or 48% in St. Petersburg, 63% in Tomsk. So I spoke about an average for the region, but it doesn't mean that these numbers can't get significantly higher in specific areas. This morning we've discussed about key populations. Let me say that here I'd like to define a key population as people, individuals, and communities who have disproportionate risk or disproportionate burdens of HIV risk and HIV disease, and that also lack sufficient access to HIV services, the combination of the two. And of course, if speaking of the region, Eastern Europe and Central Asia, for the reasons I showed in my first two slides, it is and it has been people who inject drugs. But when it comes to the other groups, I have in red sex workers, I have in red prisoners and detainees, and I have in red HIV uninfected partners in discordant relationships, because of course all of these groups are intertwined, and we also should look at it as a fluid and dynamic phenomenon. People maybe who inject drugs may be doing sex work for some time, then be off sex work. People who inject drugs may be in prison and then be outside prison. So there is a complex dynamics here, and I'd like to sort of warn us against the danger of just seeing category 1, category 2, category 3, and 4. Actually, these are intermixed and changing with time. Now, being in Kazakhstan, I felt that I can't go into the substance of treatment, prevention, and care of dependence without starting with the issue of methadone, which unfortunately remains controversial in this country and in many countries of the region. And let me be very clear here. What we now called opioid agonist treatment, опиоидная агонистическая терапия. This is the terminology that we should prefer to the old terminology of opioid substitution therapy, because of course, by saying opioid substitution therapy, we're sort of serving the people who think that we're substituting one narcotic to the other. Opioid agonist treatment is the most effective treatment for opioid dependence. It is the most effective. The data in the literature are comprehensive, compelling, and I think undisputable. And this with effects across many benefits, benefits in health and social benefits, including reintegration of people on OAT into society. The two medicines that enter what is now called medication-assisted therapy, which is the complex way of treating opioid dependence, are methadone and buprenorphine, and OAT is to be prescribed along with counseling, with behavioral therapies, and with social support. Methadone and buprenorphine, I would like to remind us all, have been on the list of essential medicines of WHO since 2005. Now, looking at the region, there are only few, I would say very few countries in the region where methadone and buprenorphine as are prescribed as long-term maintenance therapy of opioid dependence. And when it comes to the use of methadone and buprenorphine as part of OAT, these are illegal, as you know, in the Russian Federation, Uzbekistan, and Turkmenistan. Treating opioid dependence is a difficult task, and particularly because many people who are dependent on opioids, and my focus here is on opioids because it's still the predominant use in the region, because people who use opioids who are on what I call extramedical opioids, non-medical use of opioids. This is my way of calling it. In Russian, it's called zloupotreblение, but I'm saying non-medical use of opioids. These people are commonly, either as a primary or a secondary problem, using other substances, let's say alcohol, stimulants, benzodiazepines. They may have mental problems, and that complex of mental, social, and physical comorbidities is certainly one of the challenges for the treating physicians. In terms of the potential of what opioid agonist therapy may bring to the region, I'd like to draw your attention to this modeling, mathematical modeling study published just 3 weeks ago in The Lancet that looked at what would happen in Kiev, in Perry County, which is one of the most prevalent counties affected by the opioid epidemic in the United States, and in Tehran, as compared with a scenario with no OAT. If OAT was scaled up to 40% coverage and at least 2 years on OAT for every person treated, and also if OAT was provided in prisons, and I'll come back to that later on. If these three conditions were there, 40% coverage, 2 years OFT, and OAT in prison, that would reduce HIV-related deaths among people who inject drugs by between 25 and 56%, and that would reduce the overdose deaths by somewhere between 34 and 57%. Significant benefits from scaling up to 40% therapy. There are other ways of addressing opioid dependence, and many of these other ways are actually prevalent across the region in Eastern Europe. But let me say from the start, if you look at the last line on the slide, that the amount of evidence, of scientific evidence for these interventions in terms of effectiveness is much lower than that for opioid agonist therapy. And many of these interventions would have only small benefits on a small number of outcomes as opposed to OAT that has, as I said, health and social benefits. First, what's called medically supervised opioid detoxification, which is largely dominant here across the region. No doubt this is something that can assist people in withdrawing from opioids. However, without additional interventions and without OAT, most, if not all, people will relapse. I remember a discussion last year with the chief narcologist of the Russian Federation. He was telling that the results in Russia of medically supervised opioid detoxification are approximately 40% after 1 year, approximately 10% after 3 years, and 5% after 5 years. Psychological interventions, the evidence that they are effective as treatment, long-term treatment of opioid dependence is very mixed. What is clear is that the best the best chances for a psychological intervention to be successful is to build a solid, high-quality alliance between the clinician and the patient, and also have a clinician-led support that is integrated with a peer-led support from peers, either people using drugs or people from the civil society in general. There is an interest in the region in extended-release naltrexone that was pioneered in St. Petersburg, and particularly because there is no access to methadone OAT in Russia. The problem with extended-release naltrexone is that it requires people to withdraw before they initiate treatment. And the second problem is that the evidence on retention at this time is fairly weak and inconsistent as compared with the evidence we have on OAT. Now, that said, I'd like to come back to what I already said, that drug use is a fluid behavior. There isn't such a thing as a person using drugs and a person not using drugs. Actually, there are people who use drugs, there are people who inject drugs. Sometimes people use drugs, then inject, then use again in other ways. Sometimes there are people who would use drugs continuously, other people who would use drugs occasionally, other people who would just use them intermittently. And then there's a variety of drugs, of course, that people may use, and often people use a polysubstance cocktail. So when it comes to whatever you use, if you inject, and that will be my focus now in this part of my presentation, if you inject, then you need to be offered harm reduction services. Harm reduction, as you know, can be defined as a set of policies or interventions that seek to reduce the harm of a behavior without requiring that harmful behaviors be eliminated. For example, nicotine patches for people who are addicted to nicotine, or alcohol-free beer, or seat belts for people who are addicted to driving cars. So when it comes to people who inject drugs, harm reduction aims to prevent the major public and individual health harms associated with injecting drug use, and that includes HIV, hepatitis, and overdose. Harm reduction started with a number of interventions, among which the key interventions pointed out by WHO are OAT, or OAT in combination with needle and exchange programs and in combination with antiretroviral drugs. And here, as I said before, the evidence is absolutely undisputable from a scientific perspective. These interventions in combination reduce heroin use, They reduce the sharing of equipment. They reduce significantly HIV incidence and hepatitis C incidence. They reduce mortality, and they reduce crime and public disorder, and they're highly cost-effective for a public decision, public program decision maker. Today, in 2019, I would add to these, let's say, medically oriented interventions, treatment of hepatitis C, in addition to antiretroviral treatment. I would add safe injection rooms, of which we have many now in Western Europe, in Canada, in Australia. I would add heroin-assisted therapy for people who, despite years on methadone, still do not feel comfortable enough on methadone. And I would add drug checking, that is the possibility for someone who buys a drug on the street to go somewhere and check the quality and check what he bought on the street is actually contains. As you know, in Canada, in the US, in Estonia, in the UK, there are now threats with fentanyl-contaminated heroin. And it is very important that people who buy their products on the street can check on the quality of what they use. All of these interventions, and that's the point of this slide, are synergistic. This is a study that was published now 4 years ago, and it's a modeling study. If you look only at the black bars, for example, it shows that if you were to decrease HIV incidence by 50% among people who inject drugs in St. Petersburg, and if you were doing only needle exchange programs, and that's what's happening now in St. Petersburg, you have needle exchange programs, but if you wish to achieve these numbers of reduction, you would have continuously for 10 years to cover 80% of the people with full coverage. However, if you were to associate a needle exchange program with antiretroviral therapy in a test and treat strategy, or if you were to associate needle exchange programs with opioid antagonist treatment, you would have only to cover 40% of the population. And if you were to associate the three interventions, a 20% coverage would be sufficient, which in my view is something we should be able to achieve across the Eastern European and Central Asian region. And I'll just quickly illustrate some of the effectiveness of OAT in the next few slides in areas that are maybe not so familiar to you. This is a meta-analysis of all the literature available, published in 2017, that clearly shows that the association of opioid agonist therapy with needle exchange programs can reduce the risk of acquiring hepatitis for someone who injects drugs by 71%. This slide is about the effect of OAT on contact with the criminal justice system. I will not go into the details of this slide, but basically what is measured here is the charge rate per 100 person years. That is how many times a person has been charged, arrested, in contact with the criminal justice system. To the left, on OAT. To the right, in the absence of OAT. And you can immediately see that the left is green and the right is red. Unfortunately, in the region, access to these interventions is very, very low. If you look at the bottom of the top panel and the bottom of the lowest panel, this is where Eastern Europe stands, basically within the lower, or if not the lowest region in terms of access to both needle exchange programs on the top and opioid agonist therapy on the bottom. it's not only a problem of access to harm reduction, it's also a problem for people who inject drugs of access to treatment. At this time, it's estimated that around 80%, as we heard from Kazakhstan this morning, of the people who inject drugs and are HIV positive know about their status. However, only 50% would be on antiretroviral therapy and 39% ultimately with viral suppression. And it's less than 5% people who inject drugs in the region that are currently accessing hepatitis C treatment. The last part of my remarks is about the broader picture. As said before, there is addressing this issue is not only a matter of medical interventions. It's a matter of creating what we call in our language the enabling environment. That is, building supportive legislations, policies, have financial commitment, decriminalizing behaviors, addressing stigma and discrimination, empowering communities, and addressing violence against people from key populations. And stigma and discrimination, we discussed it this morning, are high across the region, including, unfortunately, in healthcare settings. There are a number of barriers, and I'm having here in red criminalization for drug possession and use, which is still in the legislation in Belarus, in Georgia, and Uzbekistan. It is not in the legislation, let's say, in the Russian Federation or Moldova or Ukraine. However, in many of these countries, the thresholds that will delineate between use and traffic is so low that actually everybody will end up actually being arrested for trafficking, even with minimal doses of drugs. There are policies limiting the provision of harm reduction services, as I said earlier, in many countries. There is police violence in the name of the war on drugs. It's been documented by NGOs. It is basically routine, arbitrary detention, arrests, planting of drugs, we've heard about it in the press, extortion of money, rape, extort confessions. A recent study conducted by a community group in Russia showed among 600 people who inject drugs, revealed a medium sum of a bribe of 415 euro for drug possession in small quantities in use. That is, if you don't want to be brought to prison, that is what you have to pay to the policeman. And of course, police also uses drug users as easy catch for quality indicators. We know all of that. And that ends up with incarceration. Most countries in the region are among the highest incarcerators worldwide. In the Russian Federation, it was 650,000 prisoners in 2016, 25% of which were convicted for drug crimes. And incarceration actually carries a high risk of HIV and of hepatitis C. Again, a systematic review of the literature found that incarceration increases the risk of acquiring HIV by 81% and HCV by 62% among people who inject drugs as compared to non-recent incarceration. And there is also, as you would know, a well-documented risk of overdose death after people are released from prisons. And another piece of data came from studies of Fred Altis and others in Ukraine. And if you just look at the bottom of this slide, they have shown that 75% of TB cases among people who inject drugs, and you know that TB among people who inject drugs, in fact, is often multi-drug resistant TB, can be attributed to incarceration. And that this actually translates into about 10% of the overall TB in the general population. So incarceration of people who use drugs drives TB among people who inject drugs and in the general population. And I'll just end up by saying something we discussed this morning, how important are peer-to-peer support in helping us having people who need these services, people who inject drugs who need these services, access to services. This is a group of people I met in Donetsk who have been working under hugely difficult conditions. I find them real heroes in the region. Here is something I saw in Ekaterinburg, an NGO offering services, and it says peer-to-peer consultation, tea with biscuits, condoms, emotional support, answering any of your questions, and help in your consultation with your doctor. That's just remarkable. So let me also say that health is politics as I end this presentation. And the fact that drug policies heavily rely on prohibition enforcement, and that is an obstacle to OAT and NSP. The fact that methadone OAT is illegal in some countries, the high rates of incarceration, the low proportion of national budgets that are devoted to prevention to vulnerable groups, all of that is a political decision. And so has been the political decision to discontinue OAT in Crimea in 2014 and discontinuing OAT for people who were on that treatment in the Donbass in 2015. So what is needed? Ultimately, three things. First, a substantial global scale-up in the region of OAT as treatment of dependence and scale-up of harm reduction. Second, we discussed it this morning, integrated services for people who inject drugs, providing harm reduction combined with HIV, HCV, TB testing and treatment without restrictions and stigma, and without having the patient go on Monday or every day to the methadone clinic, on Monday to the physiater, on Tuesday to the HIV clinic, all of which will be in different parts of the city, and reforming the justice system. Decriminalization of drug use, which is now a commitment of the United Nations, and possession and diversion programs, so having the police help people access medical services rather than arresting people, and have access to services for incarcerated people who inject drugs in prison, and continuity of care on release. And I'll end up with the statement that the solution to that is politics. And this is, to me, one more evidence that health is a political choice. You choose to do this or that. It's a political choice at all levels of governance, from the rayon to the city, to the oblast, to the central government. Thank you.